So thanks a lot. We're glad it's getting towards the end of the day. Think about training. We talked about it indirectly, directly. During the whole morning, this afternoon, we think professions, remote professions. To succeed, we have to think about the way we accompany skills of all the professionals with a tool that's completely going to change everything, which is AI. Laurent has wished to show us how much we're going to be limited in our actions, but there's still a lot of positive aspects in AI. What I suggest in going around the table first, to agree on what ambition we give to training. Is it training professionals for care or professionals for health? Because we can wonder what we are doing today. I suggest we go around the table and to enter on this ambition, each one of you in 1 minute. Françoise. Thank you for giving me the floor. Training is confronted, is facing, we saw it with innovation, conservatism, we mentioned that, and human. This is fundamental, and human is able to do the best, and in the end, I would say, there are still fault lines. The ambition of the patient, because this is what it's about. The ambition of the patient who's brutally confronted to changes in his own body. The emergence of disease is so the wish to be cared for, to care, and to be on a path that's life path and of care. And here we have fault lines. We talked about coordination, and often I take this example. It's the patient who says, I'm the coordinator, I am sick of it, I don't want to be the coordinator, that's one of the issues, and that's one of the human problems. The big idea is that beyond these innovations, human is what's going to dominate in face-to-face with the patient, so to train for health and not just for care. Absolutely. That's about it. We continue our roundtable. As an expert of training for care, I think it's important to share with you the fact that we excel, and it's for years of training doctors for care, the process of diagnosis, treatment, etc. And revolving around this, there's a whole human activity, and as a training institution in the medical faculties, we're taking aside on this dimension beyond care, with confusion, and the line is not clear between both. So what we wish to say as a positive element, the reform that you all heard of in the health studies touch 3 cycles of the whole training process up until interns, with a pedagogical transformation, the setting up of approach by skills. It's important to realize that this transformation, we did it, and this approach through skills is the opportunity to tackle something else than care, but to remain in this approach by skills, and maybe I could get to that. So do we have to go further on this health dimension? Of course, it's essential. Health is the basis, and then we have to, care is the primary thing, and then we have to move on to health. Macha, what does the university and the Conference of French Universities? Universities don't think medicine, they think health, and all the professions, the health professions, not just medical job lines, but paramedical. Also, first, the president, who see all the first cycle reform, the entering, so it touches not just all universities, not just the medical universities. The reform tries to bring together all the training. I wish to talk about, to talk in the name of all the presidents. We want to train on everything if the health system facing us is clearly organized. I'm going to take the example of paramedics. So the report from Yvon Berland on the universitization of paramedicals, 2002. We're in 2025 now. Nothing has never really changed. We're in the middle. We think health systems, and we think students that trust us. We continue. Cyrille, what ambition for training? hard for me to talk about training for health professionals as industry leader and French citizen who benefits from the health system. We have a very good health system. Training is very good. Technical level. Nevertheless, I think that on the human level, sometimes we can be welcome and there can be improvements. But there's one thing that, as an engineer, I could go abroad during my training, and I think it could be a plus for some health professionals to benefit from 1 month, a few weeks abroad to see how things are going elsewhere. Sometimes there are programs that could be called to, can bring a plus. We talk about AI. Yes, there's a lot of AI, but what about as an industrial? We bring a lot planification, augmented reality. We're going to get to that, but on this dimension, this ambition, it's a very technical. Do we remain in the technical and the health, or another dimension regarding everything we said this morning? There's a dimension, a human dimension, but there's also a technical dimension. Today, everything that's automation, equipment, and augmented reality, we're going to have to improve training on that, and we have to be ambitious. So, training in health. Thierry, President, as a community, we have to train on health first. And what we can observe that we train more for care. And we have a vision of care, technical aspect, and not health in general. And we look at the determining. So to care is just 20%. When we look at life expectancy, evolution, and people's health, not everyone can have the same share between care and prevention. We need a common culture. We don't have it yet. It goes back to training. I think there are moments we need common modules that we work together and internships, and then we have topics we can work on. So we have a real ambition to accompany this whole health reform, the health system reform. These skills have to be, but we have to be performant on the technical aspects. So this training, to get more into details, how should it meet the needs of the patients? Because in the end, as we talked about it, Agnès Buzyn showed clearly that there are many players, not just professionals in their own corner. What are the requirements for tomorrow for health professionals regarding patients' expectations? What are the things we have to work on, especially in this human dimension? Patients, they expect, of course, efficiency and security. Nobody can deny the professionalism of health professionals throughout. So there's a theory, there's a political, that's very mechanical. And we hear even patients say that, not just doctors, surgeons, practitioners. I'm going to repair this. The patient says, are you going to repair me? Are you going to fix me? Are you going to heal me? There's this theory, and next to that, there's the whole aspect that's less technical, I would say humanistic, and that makes the patient, we can see, lacks information. We have to train, absolutely, to inform. We have to train teams. Individually, collectively, information is lacking to the patient. A person that's in the room told me here, I was hospitalized for X reason. I didn't see anyone for one day. A day and a half, maybe I saw one mopping around, but I didn't see anyone. And that's surprising in a hospital. And suddenly, the following day, 15 people entered the room, talked among themselves. I was told, okay, you can leave. And the nurse will explain to you the treatment. Goodbye. That evidently is, I think it's rare. Nevertheless, it just happened. another decider who gave me permission to talk about it, a great person, hospitalized still. He was told it's a bit troubling. A friend of him made him enter the hospital. He was kind of lost first evening. He was suggested a treatment. The next day, I said, hello, next day, so did you pee? And he reframed things. And he left. So there are things that go beyond the humanistic aspect. So beyond technology, beyond targeted training, this is remarkable. It is useful. Beyond the virtual aspect, it's a great source. And there'll be other inventions. I think absolutely need to train on the human aspect and to train on information. So what's striking? Twice you talk about information. Is it first to listening? Listening. We talk about first the X-ray, and then we speak to the patient. You're right. I talk about dialogue, a constant, continuous dialogue that can be without words, just looking at the other patient. I can tell you, look a lot. The patient is nonverbal. Is there a training revolving around nonverbal communication on this specialty? Yeah. Yeah, we work on the nonverbal. What we do is, which is new, is we work a lot on putting into real. So first we did practice in real life situations with a group of caregivers, visiting hospital beds, and indeed, yes, we put them in real life situations. So to get your degree, several times you're put into real life situations. And if you don't perform, you don't have the good grades. So that's one of the foundations to rethink. It's already been rethought in this way. And to learn silence, the role of silence. And I'm not sure we teach silence to our students. The observation is that if we 0 to 10, where are we? So there are 10 stations to visit. They had 7 minutes per station. So we have a revolution to do. So 8,000 people in 2 days, over 40 sites, and it functioned well. We're the only country able to do that. So how do we improve? So we start, we're the first country in the world to have an exam on tablets. So listening and the role of science. Thierry, we spoke about patient and regarding the needs of patients in more pathological departments. So to bounce back on this, I think it's heterogeneous from one university to the other. We don't have necessarily that we use real-life situation simulations to announcement for diagnosis or an interview with the patient. I don't think it's not enough part of what we do. How we prepare future doctors. They're very well trained on the technical aspects, but announcing a diagnosis in the interview with the patients. In listening, we undervalue real-life situations, and so that's a work in progress, yes. Regarding the evolution of the needs of patients, under my perspective, from hospital perspective, what we notice is that training currently is too specialized. Too specialized. We need it. I'm in La Rochelle, a big institution. We need specialists. We need people very competent. But what happens currently? It's the whole geriatric tsunami, chronic disease, went to acute disease to chronic disease to episode of care, to the whole healthcare path, to the coordination of different sources. And we have the feeling that there's a hole in the racket. Today, we recruit practitioners who are very well trained, but don't have a global vision, a holistic vision of the patient, and they're in difficulty. Who stays in a bed we have in ambulatory, we have old people, polypathology, that are not necessarily old, and we're in difficulty taking charge of them, taking care of them, because they haven't learned in their daily practice to do that. And that's a difficulty that we're facing. And we talk about geriatrics. There's a study from the FHF with institutions that show that geriatrics has become the discipline most in tension, and the needs are growing. We need it in geriatrics, out, mobile teams, into hospital. We need it in out-of-hospital structures, and we have polypathological in medicine, and we have difficulty, and the needs are. I'm in a hospital where in a few years I went from 30 beds in geriatrics to 300. And the training doesn't match that need. The training is very focused on, and internal medicine is too specialized, and we have trouble recruiting them. And what happens in practice, we get general practitioners attracted by hospital practice, but they're not well trained, and they're trained on the job. We have, and that we really have concerns. If we don't think of a pluridisciplinary training, either we can evolve on the degrees that we deliver, a 2-year degree, I don't know, but many hospital centers, not the small ones, they're going to be in great difficulty because multitask, polyvalent doctors are needed, and I have them in oncology, psychiatry, surgery, cardiology. And the hospital are going to health institutions, those who take care of polypathology, orthopedics. And that's a huge difficulty. An example of what happens, we talk about hospital-centric vision. I did a study. Since 2019, the number of hospital stays has doubled. Every day is 19 extra beds for patients that are in the hospital because we lack an alternative. So before getting the floor back to you, what you said about the skills of doctors, we look at these new pathologies. Is it the same thing that you do for nurse personnel? Notion of polyvalence is the same for nurses. We need something that has a global view, and today they lack this kind of flexible, adaptable. I'm in favor of cooperation and sharing skills and advanced practice in nurses, but we need a general coordinator of care. And AI is not going to answer this. Think to an orthopedics, put him on insulin, diabetic. So. Last word for Françoise. At what point our health system, which was known as the best in the world, has turned? How can we understand that there's a leak of practitioners, nurses, doctors leave? There's a drain. The studies are too long. Medical studies too long, and we're not following the right axis. And what you said is true. Patients, they spend very little time, even for an acute disease that's going to become critical. They spend 0.003% of their time in the hospital. The exercise of students, the training of students wherever they are, is at the hospital. That's fatal, because patients live in the city. They're sick where they work, where they have children, etc. That's what the collective error that we made. And patients, in the end, when they have a problem, if it's chronic, they go to the ER, which have become kind of the general practitioners for French people. That's a collective mistake. But I think there's been a bad steering of the bad orientation of the studies. And this is important, I wish to say, talking about studies of pharmacy, and the professionals, pharmacists, are not enough close to their patients. They should be directly related to the patient from the beginning of their studies in a long time, and to get immersed with the face-to-face with the patients, whatever the technology or sophistication, and then we see that it questions a lot our system. We talk about hip replacements, and what's the role of industrials in training. Today, what is this investment that we have in initial training and lifelong training of health professionals? Clearly today, technicity that is brought today and that's evolving. When we put a hip replacement, hip prosthesis, and we have a simulation before, that's not already, and we have the robot now. I'll take my coffee while the robot works, and in X-rays, everything is automated. The industrial today has always participated to the training. So where does this investment come? Can the industrial continue to invest? We pay apprenticeship tax. We're allowed call on for trainings. It's necessary. So that the DMs are well used. But we have a funding issue and this economic situation today. The budget today are tight. The price of prosthesis are decreasing, the cost is decreasing, inflation has impacted the industry. Maybe we'll keep the funding later. I would like, sorry, I didn't forget it. I would like us to react. These two interventions question our training system a lot. I would like to have your opinion, both of you, Macha. How can we accompany this transformation, which is a strong requirement? And where's the place of university in the system? We talk about what's very interesting in the current debate is that each talks about their own perspective position. Olivier talks about the dean of a faculty of a university. Thierry talks about his position as hospital director. Cyrille talks about his perspective as an engineer and his commitment. Today, those who speak the most of the system is Françoise. The health system is Françoise, and we need this transverse vision. University has assets that are not enough mobilized. We could say that what happens currently with the reform of the reform of the first initial training could be a first lead. A pluridisciplinary university has always had engineering school. I have an engineering school on medical devices. We always have this plurality that should allow maybe to bring students to be listening to their patients, be able to be in private practice or ambulatory or hospital, being able to think health. Doctors, of course, because they crush all the rest. Through other professions, medical professions, and I can't tell you about dental surgery, you know in what shape it is, but you have the 27 paramedical professions and all the emerging trades and professions. I think we should really have this global broad vision to try to, in the same movement dynamic as it was done, and then the pandemic arrived. We should introduce much more transversality. By preparing the reunion, if you put philosophers, we're in a closed-off system. Yeah, we're all in our silos. Today, do you manage to get to university to move the lines, to rethink tomorrow's university? It was not at the time of Lionel Collet, but currently I'm one of the rare president of university. There's maybe two of us, over 75. They come from the hospital. And so, of course, necessarily in the strategies that I deploy, I'm going to impulse certain things. All of our colleagues have goodwill. All my colleagues have goodwill, even though they don't come from the university. And the university is not run by somebody who comes from both worlds. And so this path that we have to follow, and that's why sometimes it's complicated with my dear colleagues who are deans of university, we have to open up to to private practitioners. So I think we have the impression that specialties, cardiologists, orthopedics, they all want to do more in their training, and we learn a whole host of things that are ridiculous. Who remembers the class of biochemicals? Within our system, our corporatism, our specialty doesn't close off training and doesn't mislead us. And how are we going to try to shake that system? How do you do that? So we have to see where we start from. In medical fields, we learn the cult of excellence. We still have an exam at the end of the first year or fourth year, and we target excellence. And we're interested in training. What do we call excellence? Academic and scientific publishing, medical expertise. The human dimension is part of that, intrinsically. All the people that I met that have trained me all have a human dimension, no doubt about it. But we have to see what is required from us. Tomorrow, if you want to have a career in the hospital university system, you need to publish articles. And that's not the ridiculous part. Today is everything has infiltrated the system, which have other mission than training. What we should do, and it's happening right now, to general medicine with the degree this fourth year has an impact, of transformative impact. The process that we're able to understand that we have to rethink the training. And the easiest way to stop considering that to be a doctor, you have to be to have a PhD in science, and we can have students that are different from a pure scientific profile. We're training racehorses, and we don't need just racehorses. We need a bit of everything. This transformation, to do it, to carry it out, we try to do it. We're doing it. Quickly, Thierry. I would like to know, as Vice President of a digital university, how are you going to use digital to do this transformation? Thierry, Françoise, and then we get back. Just to bounce back on specialty and more multitasking. The second cycle, we learn everything independently from the practice we can have. I'm specialized in diabetes. Do I need to learn about stomatology? Maybe there are things. If you have a contest at the end, and we did these files, synthesis files, we have 300 items, and we have 1 page per item. And if you know all this by heart, normally, but there's a phenomenon that's our responsibility. A lot of this permanent competition, it's always the best, and they spend their life out of the university in private offices to answer questions on tablets. What was said this morning, we have complementary exams before, and so we have a real reflection to carry out. How does digital, you have this other hat, how are you going to use digital to shake training? Use 2 aspects, digital to help in the training process, and then just how you're going to prepare people for this digital revolution. So on digital, to project yourself quickly, to be very clear. Today, all the innovative systems, language models are going to help the whole apprenticeship of theoretical knowledge, and students are going to be autonomous on this apprenticeship. A place that we have to invest in using AI in the collaborative aspect. Today, there are no works done on this in AI at companies. We're sure that they're going to be accompanied on knowledge, and they're going to have, for lifelong training, is useful for theoretical knowledge. But there's an issue on the human aspect. So we have to modernize and use these tools and transform the position of the learner. And there's something that has to move, a key element. Students have to be aware early in their process that they have to acquire knowledge, but they're going to apply this in a human context. And here we talk about skills again. The first skill that they need to acquire, and it's true for the whole university, is autonomy in learning. And put them in situations like biochemistry chemicals where they can prove that they can learn and to be leaders in their own practice. And then you put the digital environment you wish, almost existing, and to have autonomous and voluntary students, we can get to a profile that's more adjusted and adapted to what we need. So more human, more autonomous. I see you react. What is wrong in the training? Why 50% of patients don't follow the directives of their treatments or don't take them well, or not at all? Why does pain? We're very bad in managing pain. 70% of patients are not relieved of their pain. We're very bad in osteoporosis, which touches 4.8 million women. And we're sorry, don't be too bleak. It's already raining outside. So, pragmatically, sitting by the side of the patient or in ambulatory, in outpatient care or hospital care, training has not allowed, up until now, for us to approach the key issues of the patient. And something I wonder about training, is it mistreated? So a lot of students abandoned their studies, and that's an issue. And something else, even worse, isn't it why it's a reflection of society, which is not well treating? That's a big issue. And I heard you, of course, to say that geriatrics, okay, our society, does it like the seniors? Does it want to take care of it? Our society, does it want to, in the social medical field, in daycare, to take care of those who are fragile and weak? And I say no. And this is, I wish we would question ours, have this global questioning. There's also there's also nurses. And my hat as industrial. And so it's very important for us to make available a certain number of personnel. We make available webinars. It's exploded with COVID, but technically it has to be efficient. And I think make a parallel. When we started, we're not used to use Wi-Fi or remote control. Today, all doctors, nurses should be able to use simulation. You said that you didn't use simulation enough. A lot of companies in medical devices have simulation tools available for practitioners that can today show their patient and plan. And this, is it clearly recognized? Does the university recognize this lifelong training that you deliver when you negotiate the price? Do we identify the fact that this training role? We have the impression that this training dimension of industrials is, it exists, we all took advantage of it, but it's kind of elusive. There's not a device that can work without transfer of skills from the industrial. We cannot say that it's under the table or it's technical. You talk about financially, maybe? That's under the table. No. What we do is that we open the hospital to companies for medical devices, so both it's more surgeons or certain specialties than or physiotherapists. The idea is to confront needs that are expressed by surgeons or doctors facing industrials that have know-how and that that want to know if their skills and technical skills can be made available. Not everybody does it. Yes, we've been doing it for 15 years, isn't it? It's an important element. We can do it. A university that wants to do it can do it. And a hospital, a university center, and financially, when you negotiate the price, whether it's a medical device, is there a line in the negotiation on matching the fact that you're going to be a training organization to a company? No, it's a package. And by the way, on the last product that were with a fixed price. The prices continue to decrease. In the economic context, we have a situation where industrials they have to pay for inflation and a lot of things. And the price doesn't increase. You're going to have trouble training us to accompany your technologies. That's an issue. There's less and less. I'm going to take some companies, rather than 10 trainings a year, they're going to do only 4. It's a choice. It's a budget choice for industrials. And when we talk about the cost of training, the money put on the table, do we accumulate well all the direct and indirect budgets? For universities, we do analytical accounting on our trainings. Not all universities have done that, but mine has a great number of work to find a clear idea, clear picture of the cost and the sustainability of our degrees. But we have to. One day, governments are clear and don't change everything. By preparing, you said like your head is spinning. So you have to rethink with a clear steering, clear driving lines, guidelines. So we have 4 minutes left. We have a health system that functions in silos, hospitals, and among professionals. And I think we have an issue with training. We have our training in silos for professionals. And at the national level, how come we haven't yet defined how we should work together? What is the role of each one? And that's an issue. And it's urgent to redefine that, because the doctors, for me, have demographic issues, and we have to refocus on our added value and other professionals. And we have to redefine that precisely, accurately, and training will be more adapted. We're not trained to work in teams. We talk a lot about coordination in the real life. Are you young people, how do you explain that if it blocks? Because we're too conservative for all of us. So today we go to see our MPs, but we don't think professionals, and that's never going to work. To rethink training, I'm a strong proponent on, I think we missed a lot of opportunities. It's absolutely fascinating. So maybe we can go around the table. What are the 3 key words to rethink training intelligently in a smart fashion? Who wants to start? Together, holistic, systemic.
On continue.
Yes, coordination, break silos, break barriers, and put this human is the variable of adjustment that's key.
Ça, c'est très fort ce que tu viens de dire.
Very strong.
Ça nous questionne beaucoup quand même.
It puts a lot of us into question.
D'accord.
C'est indispensable. Pour répondre à ces challenges, il faut de l'innovation.
You need innovation to meet those challenges.
La dimension numérique.
And you add the digital aspect, but not only how to use it to reach your objectives. Collaborative, ambitious,
et investissement.
And investment.
Pas financement, mais investissement.
Not funding, investment.
Et Françoise,
I think the distinction is clear. And the last words for you, Françoise, because for us to treat and care humanly, that we accompany in terms of health efficiently our citizens. I would say trust of professionals in themselves, in other members of the team. I heard Nicolas Revet talk about of conflicts, and it's part of trust issue. That's very important. The path, training path, and care path, follow-up, and human always, the human first and foremost. I remind you that the patient is a well of knowledge, and I sit next to him, I enter his house, I take him by the hand, and I listen to him. Thanks a lot. We have 1 minute left. We mentioned it, and Clara mentioned it, the human. That's another question, going towards others in the whole theme on health mediation, not even big degrees, and how are we able, on health mediation, there's a lot of works. Please feel free to watch, to consult them. How do we do at the ministry level to integrate in the university in terms of to accompany those new professions and people who
mais qui ont énormément
don't
de
have high
compétences
degrees, but
de
have a lot
aller
of
vers.
human skills of going towards another. I'm not sure we should expect something from the Ministry of the Government, but within universities, I'm close to my term. I can.
Et t'as 15 secondes pour lâcher.
You have 50 seconds to let go. So we have mediation trainings, because mediation is a general principle and it's applied to health. And you mentioned Nicolas Revel and conflict, and we manage a lot of conflicts. Thanks a lot.
On a des mots-clés, ça
We
nous
have
permet de
keywords
penser
we can
efficacement.
rethink efficiently.